Okay, any questions on IV anesthetics? I tried to get some key points there of things that you're going to see or things you have seen in the operating room. Okay, and I can get, if there's questions, if there's anything in the chat, I can go back to them as well. But if not, we're going to move on to chapter 11. So chapter 11 was neuromuscular blocking drugs and reversal agents. So we talked about doing a rapid sequence induction for this patient. We, let's say, used propofol to induce. We gave a little bit of fentanyl, and then we want to give a muscle relaxant, so something to effectively paralyze a patient to place a breathing tube. Two different choices. So we could give either succinylcholine, which is a depolarizing neuromuscular blocker, or a non-depolarizer, and likely it would use rocuronium. And we'll talk about those two specifically in a bit. So these drugs, each of them, they block impulses at the neuromuscular junction. So briefly, to review neuromuscular physiology. So here's the neuromuscular junction. So we have presynaptic terminal and we have postsynaptic. So I highlighted here in green the receptors that we primarily are targeting. So what happens for a muscle contraction to happen? So there is a prejunctional motor nerve that's separated by the postjunctional here with the synaptic cleft. So there is an impulse. So an action potential is propagated through the nerve. There is release of calcium, which then leads to release of acetylcholine. Acetylcholine binds to acetylcholine receptors, which are these little red things that I highlighted in green. It binds on the postjunctional membrane, which is here. The receptor opens. We have exchange of sodium and potassium, and then the muscle contracts. Clearly, there is much more physiologically that's happening here, but that is a good understanding of how these drugs are going to work as well. A muscle then is able to relax and stop contraction when acetylcholine is hydrolyzed by acetylcholinesterase, which are these light pink little dots right next to the green circle. And the membrane then repolarizes. So we have contraction and then we have relaxation of the muscle. So non-depolarizing neuromuscular blocking agents. So as I said, we have two different types. So succinylcholine is the first type. Biochemically, so if you look at the molecule, it looks like two acetylcholine molecules that are linked together, primarily by a methyl group. These activate those cholinergic receptors, so it is causing a muscle contraction to happen. Then we have our non-depolarizers. So they are primarily quaternary ammonium compounds. They bind to the receptors, but they don't activate them. And there's two different classes of these. So the aminosteroids, likely the most commonly that you have seen or are going to see. So you can look at these, anything that ends in curonium, rocuronium, vecuronium, pancuronium. Rocuronium and vecuronium are the two most clinically utilized these days. These are hepatically metabolized and then excreted by the renal and biliary systems. And then we have benzoquiliums, which are curium at the end. So these are metabolized by plasma esterases. So they are usually very rapidly metabolized. And cis-atracurium is the most commonly utilized in practice today. There are many others that I didn't list here. I tried to list the most commonly you're going to see. And after they're metabolized, they are renally excreted. So succinylcholine, let's say we gave this patient succinylcholine because we want a very rapid onset of muscle relaxant. Typically given in a dose of 1 to 1.5 milligram per kilogram, and it causes depolarization at the postjunctional membrane. It creates what's called a phase 1 block. So we see fasciculations, so the patient has profound muscle contractions. You may notice their eyelids twitch. Those are muscle fasciculations from the succinylcholine. Depending on when the dose that we give, we can also have a phase 2 block. So phase 1 block is the initial fasciculation phase, and then we have more of a flaccid paralysis after. If we gave a very high dose of succinylcholine, so let's say we gave 5 milligrams per kilogram, we create what's called a phase 2 block. So the receptors, they are repolarized, but they don't respond as normally to acetylcholine. So it's actually mimicking what we see when we give a non-depolarizer. Benefits of succinylcholine: it's rapidly metabolized by plasma cholinesterase. Can be called plasma cholinesterase, pseudocholinesterase, butyrylcholinesterase. All the terms mean the exact same thing. So typically within 8-ish minutes, we see onset, we see offset very rapidly after, especially with a single dose of that 1 to 1.5 milligram per kilogram. There can be prolonged duration of succinylcholine, and you likely read about something called pseudocholinesterase deficiency. So this prevents the metabolism of succinylcholine. The way that we assess for this, so usually it's a family history. Someone says, I was given a dose of succinylcholine. It took 4 hours for it to wear off. Likely it was pseudocholinesterase deficiency. There is a very high yield number that we talk about all the time on our board exams, and it's called the dibutane number. So dibutane is a local anesthetic that inhibits pseudocholinesterase. We look for a normal response of about 80% inhibition of pseudocholinesterase. Anything that is lower than that, so 20 to 60%, we know that succinylcholine is going to last longer because it's not going to be metabolized as rapidly. So clinically, succinylcholine is greatly utilized because we do get that fast onset, typically 20 to 30 seconds onset. So in rapid sequence inductions, it is invaluable because we do save a tad bit of time getting that breathing tube in. There are some side effects though, so it is not super readily used, especially with other medications we have. So succinylcholine, because it is molecularly 2 acetylcholine molecules combined, it can mimic a lot of the effects of acetylcholine. So we can see a profound bradycardia. Typically, the times I've seen this have been in very small neonates. So it's something we need to prepare for to make sure that that bradycardia doesn't become fatal. You do see a rise in potassium, so it is a normal response. So we are contracting muscle. So we normally you'll see about a 0.5 milliequivalent per liter rise in potassium after a single dose of succinylcholine. So in patients with underlying hyperkalemia or acute hyperkalemia, it likely is not the right choice medication to give. That being said, so burn patients, especially 24 to 48 hours after a burn, we can see upregulation of these post-junctional receptors. So giving a single dose of succinylcholine, we can see a more acute rise because of increase in receptor location. So more of a hyperkalemic response in that 0.5 milliequivalent per liter. It is a malignant hyperthermia trigger, as are all the volatile agents. So in someone with an underlying history of MH, a family history of MH, we want to avoid it. We're not going to go into malignant hyperthermia today because, as I said, we have a lot to cover. But this is a disease that is inherited in families and very linked to anesthetics that we give. We want to avoid in patients with underlying myopathies. So patients with underlying myopathies, we will see a more profound hyperkalemic response because there's more muscle mass. I typically rule of thumb avoid it in any boy patients under 4 years of age because they can have some undiagnosed myopathies. That is one reason to avoid it. Other side effects: patients who get succinylcholine will wake up with likely a lot of muscle aches, so myalgias, and that really can't be treated or prevented. There was a theory that giving a non-fasciculating dose, so of a neuromuscular blocker, so rocuronium prior, can prevent myalgias, but there really is nothing we can do to prevent those myalgias that are happening. It can increase intraocular pressure and intracranial pressure, but the clinical significance of that is, again, questionable. So yes, in theory it will, but again, we have a neurotrauma patient who has an intracranial hematoma. We need to decompress it. They're not intubated yet. They have a full stomach. Succinylcholine likely still is the correct choice in that instance because it's going to give more rapid intubating conditions than any other medication that you would give. Okay, so does the SUCS contraindication still apply? No application, approximately 24 hours burn crush injury. Yes. So that is a contraindication. It is a not a relative. It is a necessary contraindication. So you would avoid SUCS after burn and crush injury. Typically, we see it. I avoid it in any burn patient whatsoever, but typically it's within the first 24 to 48 hours that I would avoid. All right, non-depolarizers. So only one depolarizer, succinylcholine. Non-depolarizers as many. These prevent transmission of the action potential by binding to postsynaptic receptors. So it prevents any potential from going through and prevents muscle contraction. So you can think of it as a flaccid paralysis when these are being utilized. It has a fast onset, but not as fast as succinylcholine. So usually we're giving a dose of rocuronium of 0.6 milligrams per kilogram. We typically will have very good intubating conditions within the first 3 minutes. A dose of 1.2 milligrams per kilogram. This can be utilized to facilitate rapid sequence intubation. So if we do need that very fast intubating conditions, this can be a choice if succinylcholine is contraindicated. You're not going to get as quick. So when I say not as quick, typically 40 seconds to a minute. So succinylcholine still is more rapid in onset. And all of these non-depolarizers are going to be potentiated by the volatiles. So speed is relative to dose here. So the only fast onset neuromuscular blocker is going to be rocuronium. So yes, it is relative to dose. If you want a rapid sequence dose, 1.2 milligram per kilogram is the dosing. The typical dosing that we would give if we're not doing a rapid sequence, it's typically 0.6 milligram per kilogram. So higher dose of rocuronium, faster intubating conditions. All the other non-depolarizers, it is not going to be any different in terms of what you give. So it is not dose dependent. There typically is only a single intubating dose, not a higher dose that you can get rapid sequence conditions at. So that's one benefit of utilizing rocuronium comparatively to, say, vecuronium or cisatracurium. And then all non-depolarizers are potentiated, so meaning that they have mechanism increased, duration increased by the volatiles, which we'll again talk about later. So non-depolarizers, we need to monitor them. So succinylcholine, typically we see that decrease in response. We see the regaining of muscle function after that 8 to 10 minutes, so after it's metabolized. Non-depolarizers, though, it's very variable in how they're metabolized, and again, very dose dependent in what you're giving. So we need to monitor them, and we typically, I mentioned here the two most common things that we're going to monitor. So one is the train of 4 ratio. So we place a nerve stimulator on the ulnar nerve, and we're measuring the adductor pollicis. So we're measuring response, and you're seeing twitches. So seeing, yes, is a qualitative function, but to assure that we are fully reversed at the end of an anesthetic, we want a quantitative number. So we're comparing, so typically it's a train of 4, so we're stimulating 4 times, and we're comparing the 4th response compared to the 1st response. We want that ratio to be greater than 0.9 to assure that we have fully reversed the neuromuscular blockade. Other things that we measure, there are other things that we do measure comparatively, but the most clinically useful in my mind, another thing would be to monitor the post-tetanic count. So we put a sustained stimuli, so let's say 50 hertz on our nerve stimulator for 5 seconds. After that, we're assessing our train of 4 to assess if there's any post-tetanic count. So we're trying to get acetylcholine into the membrane and see if there's a still residual blockade. This is very useful, especially when we're dosing sugammadex, which is the most common reversal agent these days. So we can monitor the most clinically important thing to monitor is clearly on emergence prior to extubating a patient. However, we can also monitor these during a case to assure that we have profound neuromuscular blockade, which can be useful in some surgical procedures. So it should be monitored all the time, but definitely on emergence, and we definitely want that quantitative response rather than a qualitative response. So reversal agents, I know I sped through a lot of that, but the vols are going to take up a lot of time. So there are two different ways to reverse a neuromuscular blockade. So succinylcholine, we wait for the medication to wear off, and we wait for repolarization and response of the muscle to acetylcholine. To reverse neuromuscular blockers, so I can't believe I'm saying this now, the old way of doing it, because we now have new pharmacologic agents, was to try to antagonize and flood the neuromuscular junction with acetylcholine. So we want to prevent the breakdown of acetylcholine. So we give, most commonly, neostigmine, which is an acetylcholinesterase inhibitor. So acetylcholine is more readily available to then competitively inhibit the neuromuscular junction and therefore block off the neuromuscular blocker and let it be metabolized. Neostigmine can come with a lot of cholinergic side effects. So we typically will pair it with an anticholinergic agent, and glycopyrrolate is the medication to pick for that. There still is clinical relevance to this, especially in certain patient populations. But neostigmine does come with a bigger side effect profile than Sugammadex. So Sugammadex was FDA approved 3 to 4 years ago at this point now, maybe even more, 5 years ago now. It is an agent that encapsulates our steroidal neuromuscular blockers, so rocuronium and vecuronium. So it basically takes it, encapsulates it, prevents all activity of that agent, prevents it from having a neuromuscular blockade, and lets it then be metabolized. So it is a much quicker, much more reliable, and less side effect profile medication. So here are the two different ways that we can reverse a neuromuscular blockade. So we have a neuromuscular blocker, one Sugammadex here. It encapsulates it, prevents it from being utilized, and it is eliminated from the body. The other is to flood the neuromuscular junction with acetylcholine to let acetylcholine act rather than the blockade that is provided by the neuromuscular blocker. Still very clinically relevant, both of these, I would say, in the past 3-4 years, especially in adult anesthesia. I think Sugammadex is being much more readily utilized nationally. And in my mind, it reverses much more reliably than the neostigmine glycopyrrolate combination. All right, any questions on neuromuscular blockers?